Okay, so why am I wearing my official Starfleet medical parka? Two reasons. Yesterday, I watched Captain Kirk, William Shatner, at the age of 90 go into space. And I'm jealous because I want to go to space. The second reason is it's a good segue into our next video, hypothermia and the ACLS patient. Starting right now. Okay, now that we're back here on Earth, let's talk about ACLS and hypothermia. How do people develop hypothermia? The literature cites three main causes. One, extreme exposure to cold. Two, cold water submersion. And the third are folks that got exposed to cold but had thermoregulatory issues. What kind of people are these? The elderly, the malnutritioned, patients that take a lot of medications, which is any patient who's seen a doctor in America. Mental patients, patients with Alzheimer's, for example, that could wander out into the snow. Drug and alcohol, and snowmobiles. That can also cause hypothermia. And these represent the majority of hypothermic patients that we're going to see that we have to treat. Now, let's go through the different phases of hypothermia. Starting with a mild hypothermia, which is about 36 to 34 degrees Celsius. And the hallmark of mild hypothermia is shivering. Shivering is a good and a bad thing. It's a good thing because it's a central way for the body to warm itself. If someone's shivering, they're cold, their body's trying to generate heat and warm themselves up. However, in the presence of an MI, this is a really bad thing. Shivering can increase myocardial oxygen consumption by 600%. Yeah, 600%. It can increase cerebral oxygen consumption by 150%. So shivering is a bad thing. Oftentimes with fresh hearts, people that just came out of cardiac surgery, there'll be standing orders to treat for shivering, to give them medication to stop them from shivering, just for that reason. And you would think, well, just keep them warm. It's the anesthesia that's actually causing the shivering. So that's a big deal. If they're having an MI, we do not want them shivering. Next up, moderate hypothermia. And this is a body temperature between 34 down to 30 degrees Celsius. The hallmark of moderate hypothermia is increased loss of mental capacity. They're becoming more and more confused, disoriented, and know that at about 32 degrees Celsius, they'll lose their ability to shiver, which means they can no longer generate body heat. So moderate hypothermia, 34 to 30 degrees, they're getting mental issues and they stop shivering. Next, severe hypothermia. And this is a body temperature less than 30 degrees Celsius. The hallmark of severe hypothermia, loss of consciousness. Loss of, or the progression of signs of life. They don't look like they're living anymore. Respiration stop. If you have them on a monitor, they're probably in VFib. Loss of pupillary reflex, loss of deep tendon reflex. For all practical purposes, beyond the VFib, they're going to look dead to you. Severe hypothermia. Next, believe it or not, we have another category, profound hypothermia. In this case, they're a dudesicle. They're frozen. They have no signs of life. A cardiac monitor shows asystole. An electroencephalogram will show no brain activity. So there is absolutely no signs of life. The patient may have become their own backboard at this point, but that is profound hypothermia. So let's talk about treatment for the hypothermic patient for a moment. In all cases of hypothermia, you will always provide passive rewarming. Now, in the mild hypothermic patient, we're always going to do this. You may consider active rewarming, but we're always going to start with passive warming of the patient. So what is passive warming? Beyond taking them into a warm environment, getting them away from the cold, get the cold clothes off them. If it's wet, get the wet clothes off them. But when it comes to passive warming of the patient generates the heat. You can put a blanket on them, those little thermal aluminum wraps, but no additional heat beyond the environment is added to the patient. the patient generates the heat. So on a test, what's passive rewarming? The patient is generating their body heat to warm them up. We're just moving them into a warm environment, but we're not putting additional heat on them. Now, if your patient has progressed to moderate hypothermia, we're going to employ active external warming. And these are warm packs. The groin, the armpits, around the head. These are major areas of heat loss. Plus, instead of going all over the body, if we keep it there, we can still get to the chest. Should the patient arrest, we can still perform vascular access, airway management. But again, warm packs. Be very, very careful with these warm packs because they can burn a patient. I've seen it happen. So make sure there's always a barrier, especially with these chemical heat packs, between the heat pack and the patient. But once they get to moderate hypothermia, active external rewarming. If the patient is in severe hypothermia, again, we always have our passive rewarming. We're going to employ active external warming, and we're also going to introduce active internal rewarming. The administration of warm IV fluids, warm gastric lavage, warm rectal lavage, but at this point, we're warming the patient from outside and from the inside. So we kind of popped up this chart here of different methods of active internal rewarming. The warm humidified oxygen, warm IV fluids, warm gastric lavage, and their temperatures up there. And each of these can usually raise the body temperature about 1 degree Celsius per hour. Now the Mac Daddy, the best technique, ECMO, extracorporeal membrane oxygenation. We're going to put them on ECMO. This can raise the patient's body temperature by 1 degree Celsius every 5 minutes. So if you have an ECMO team, you have a severe hypothermic patient, call an ECMO alert and use ECMO. We can take the blood, we can oxygenate it, we can clean it, we can warm it and return it to the patient. And if they're in cardiac arrest, we can provide circulatory support at the same time. So the best treatment would be ECMO. Now, regardless of what stage of hypothermia the patient's in, begin BLS support. If they're not breathing, bag them, begin chest compressions. If we find them in VFib, we get a monitor on them, we find that they're in VFib, and we really don't know their body temperature, administer 1 shock. We may have to wait until the body warms up for those shocks to be effective, but they do recommend administering at least 1 shock immediately when we find the patient. Other considerations in the hypothermic patient: drug administration. Under 30 degrees Celsius in a severely hypothermic patient, we really don't want to administer any medications. The reason is that enzymes in the body at that low body temperature don't work as well. Those enzymes are needed to make the drug bioavailable to the patient so the body could use the drugs, and then other enzymes are needed to clear the drug from the body. The reason we don't want to administer it is we're going to give a drug, nothing happens, give more of the drug, give more of the drug, more of the drug, nothing happens, patient warms up, boom, the drug goes to work and we have a lot of it. Or you can give a drug and the drug just won't stop working. So that's why we're going to defer drug administration in severe hypothermia. Other interesting things, your patient may become hyperglycemic because at very low body temperatures, the insulin doesn't work as well. Coagulopathies can occur. Cold patients can't clot. So if it's a trauma patient, you gotta warm them up because their bleeding time increases as they get colder. Now this has been just a quick review of hypothermia and ACLS. Thanks for watching. I'm Mark. See you in the next video.